Good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 15F, which is Hematology and Erythrocytic Diseases. And we are streaming live from AIIMS Bhubaneswar via Kolkata. And today we have a very interesting topic, the Congenital Dyserythropoietic Anemia. And to talk on that, we have Dr. Somanath Padhi, who's an MD in pathology, and presently she is an associate professor in the Department of Pathology with laboratory medicine at the famous AIIMS Bhubaneswar. With post-MD teaching experience of more than 15 years, he is a life member of Indian Association of Hematology and Transfusion Medicine, Indian Association of Pathology and Microbiology, and the famous Indian Myeloma Academic Group, with areas of interest in hematopathology, lymphoreticular pathology, pathology of the bone marrow, plasma cells, myeloma, hemophagocytic lymphohistiocytic disorders, and leukemia and cytogenetics, with more than 50 papers in international and national Indian journals, and he has authored 3 book chapters as well. Before I ask Dr. Padhi to start, let me request all of you to keep your mic muted, your camera off, and please don't share your screen. With this, may I request Dr. Somanath Padhi, sir, please share your screen. Let's start.
Is it fully visible, sir?
No, sir, we can't see your screen yet.
Change the layout. Just a minute, sir. I am rejoining it.
No problem. Can't hear you. You are muted, sir. Just unmute your mic, please. Yeah, I can see your screen.
My slides are now fully visible now?
Yeah, make it full screen, please.
Yes.
Yes, sir. Good to go. Please start. Thank you.
Thank you so much, Professor Nadeem, sir, and my esteemed teachers, my colleagues, my dear students at All India Institute of Medical Sciences, and everywhere, wherever, my former institute, Pondicherry Institute of Medical Sciences, and all my colleagues throughout India. It's a wonderful opportunity to speak on an interesting topic, which, if I remember correctly, I have seen only maybe 1 or 2 cases till date when I was a resident in pathology, MD resident pathology at Sri Ramchandra Bhanja Medical College, Cuttack and Hospital in Odisha from 2005 to 2008, where we used to have a lot of discussions in pediatric hematology with my mentors there. Professor Dr. Sukumar Chakravarti was my guide, and Dr. Pranati Mohanty was my co-guide, where we have seen some cases. At least we brought this differential diagnosis of this bone marrow morphology on this congenital dyserythropoietic anemias. So before I start, I must thank my junior resident here at Department of Pathology at All India Institute of Medical Sciences, Dr. Tapas Kanti Parida, who happened to present this topic under my guidance a few months back, and some of these slides I have taken from Dr. Tapas. Here. And when they classified again practice congenital dyserythropoietic anemia with capitis and multiplication so let me to this of congenital anemia from someone and and the what was erythropoiesis. With what does this word ineffective erythropoiesis means? That means there is increased erythroid production, increased erythroid maturation, but all these erythroid precursors, they face an premature death inside the bone marrow because of the increased apoptosis. Before they are released, the mature forms are released into the peripheral blood. So ineffective erythropoiesis with intramedullary destruction of the red cell precursors and often decreased half-life of the circulating red blood cells that gives rise to the anemia. The WHO specifically states that in fact it recommends that whenever we say that dysplasia or dyspoiesis is there in the bone marrow or in the bone marrow cells, at least 10% cells of the erythroid lineage should be morphologically dysplastic to declare this dysplasia as of erythroid dysplasia. Now, when to suspect a CDA? Any patient with a congenital history of congenital anemia, with a history of hydrops in the previous pregnancies, is a strong suspicion towards congenital anemias. Any form of congenital anemia could be a CDA, unless means we need to be evaluated properly in that line. So any congenital anemia, usually without neutropenia or thrombocytopenia. And because when we have a neutropenia along with thrombocytopenia, there are so many causes. One of them is also type of bone marrow failures, also the different causes of inherited bone marrow failure syndromes also we have to bring into that. But typically CDA, as I mentioned about that, CDA presents with congenital anemias in the absence of neutropenia or thrombocytopenia. There should be evidence of ineffective erythropoiesis. That means a suboptimal reticulocyte response or degree of anemia and erythroid hyperplasia. Whatever reticulocyte response is expected in the peripheral blood in response to anemia is not happening, even though there is presence of severe and there is presence of good erythroid response in the bone marrow. That is known as suboptimal reticulocyte response. Because of the intramedullary destruction of the erythroid precursors in the bone marrow, there is also release of this bilirubin which into the plasma, and that produces unconjugated hyperbilirubinemia unrelated to peripheral hemolysis. Just to differentiate that this condition from peripheral causes of hemolytic anemias, there is increased proportion of dysplastic erythroblast in the bone marrow, morphology wise if you see this, and there should be evidence of iron overload. So all these features, if it is present, then we can suspect that this patient could be a case of congenital dyserythropoietic anemia. So while we say that it is a case of dyspoiesis or dyserythropoiesis, always we should remember that there are numerous causes of dyspoiesis, and the morphological features of dyspoiesis is not only restricted to CDA. So many causes are there. We need to see that it could be a case of myelodysplastic syndrome or chronic myeloproliferative neoplasm, whereas it could be a congenital dyserythropoietic anemia. Thalassemias are important causes of erythroid dysplasia in the bone marrow, and also because of the continuous iron transfusion and iron overload, because of the iron-related cytotoxicity. Even the trilineage can show this morphological features of dyspoiesis in a patient with long-standing transfusion-dependent thalassemic patients. Hereditary sideroblastic anemia is another classic example where you can see that presence of dyspoietic erythroid precursors in the bone marrow. Any causes of that leads to HLH, hemophagocytic lymphohistiocytosis, is another example. Last but not the least, these two things known as paroxysmal nocturnal hemoglobinuria and aplastic anemias are also classic examples where erythroid lineage, specifically in aplastic anemias, residual lineage which is left out in the bone marrow, is very commonly they display dysplastic morphology. Also, in another group of relatively more common but somewhat treatable is classic. We all know that megaloblastic anemia is a classical example of acquired myelodysplasia, which is treatable. Nutritional cause, infections. Any infections can lead to infection-related myelodysplasia. Intoxications, alcohol, drugs, and also hematopoietic stem cell transplantation or cancer chemotherapy. The lot of dysplastic morphological changes that occur in the bone marrow. So this dyserythropoiesis can be morphological manifestation of dyserythropoiesis. As we can see that it can be nuclear features of dyserythropoiesis, it can be cytoplasmic feature of dyspoiesis, and as you can go next, you can see that this diagram is that beautifully describes what is known as the nuclear features of the dyspoiesis in the bone marrow. Of course, there are many features which are present, which I have not mentioned here. Is that the first is the presence of this microcytosis, micromyelocytes, presence of basophilic stippling, and Howell-Jolly bodies, and all these features in the peripheral blood seen on this pseudo-pelgar hue type of neutrophils, neutrophil hypogranularity, or coarse granularities, giant platelets, or a dysgranulopoiesis in the platelets. These are all features of the dyspoiesis in the peripheral blood. But in the bone marrow, if you see that in this particular case, this is typical known as nuclear budding. That is very bizarre appearing. Multiple buds are coming from this nucleus. This is nuclear budding, and presence of megaloblast-like nuclear changes, like nuclear chromatin appears like a megaloblast-like. There is a presence of binucleated forms, and these binucleated forms, when they are joined by means of very thin chromatin streaks, this is known as internuclear chromatin bridging, and there is presence of cytoplasmic fraying, and there is these are all nuclear hyperlobulation. Then bi and multinuclearity, increased nuclear membrane irregularity, presence of karyorrhexis, and all these features points to the nuclear features of dyspoiesis. Whereas in the cytoplasmic features of the dyserythropoiesis, if you can see here that this presence of the cytoplasmic features is that normal erythroid precursors, they do not show this cytoplasmic vacuoles. When you see that presence of cytoplasmic vacuoles, there is a feature. This is a feature of dyspoiesis. And in chronic alcoholics, those who drink beans alcohol, beans drinkers, they have a typical, this vacuolation is not very uncommon. It is classically seen in those alcoholics, so along with the megaloblast like changes. Normal erythroid precursors, they are not positive for, they do not stain positive reaction for iodic acid skips, but when they are dyspoietic erythroids, we can use iodic acid skip staining to demonstrate that there is a presence of diffuse cytoplasmic positivity, however weak maybe it may be, but that positivity also points towards an dyspoiesis in the cytoplasm. The presence of, as you all know, that there is a cytoplasmic vacuolations, and you can see this is a pulsed Prussian blue reaction. This is the presence of this. This is known as pathologic sideroblast, and we can see that there is presence of this coarse granules of hemosiderin, which are located in a circumferential location around the nucleus. They are not located in the nuclear membrane; rather, they are located in this. In the mitochondria, which is located around the nucleus. So that's why they give an appearance of a circumferential or at least 6 granules, which are coarse in texture, which is occupying at least 1/3 or more of the nuclear diameter. That means inside the mitochondria, which are located around the nucleus. This is a classic definition of what is known as ring sideroblast, and this is the hallmark feature that we see that in patients with myelodysplastic syndrome. So these are the all features of, so pulse Prussian blue stain is an important stain that demonstrates the presence of this ring sideroblast dysplastic erythroids, as well as PAS stain can also be useful, which can demonstrate the dyspoietic erythroid precursors in the bone marrow. So once we say that there is presence of dyserythropoiesis, we can grade this dyserythropoiesis into up to 10%, as I mentioned, that at least 10% morphological features of dyspoiesis should be considered significant, and but up to 10% is considered normal, which is 11 to 25% is considered as mild, whereas 26 to 50% is known as moderate, and more than 50% of dysplasia is called as severe degree of dysplasia. So the Vikramasinghe et al. They described that 15 cases of congenital dyserythropoietic anemia with this classic clinical, biochemical, hematological, and electron microscopic features. And before they start, what exactly they did was they took 10 healthy individuals and they wanted to see the presence of any morphological evidence of dysplasia, which was they found like cytoplasmic stippling, cytoplasmic vacuolations, inter-erythroblastic cytoplasmic bridges, markedly irregular or karyorectic nuclei, Howell-Jolly bodies, binuclearity, internuclear chromatin bridges. And in the right hand side, this is the percentage of this mean percentage of erythroid blast, which showed this type of things, dysplastic features, which was almost less than 1% of these erythroids did so. In normal individual, we can also expect that very occasional less than 1% of the blast erythroid precursors can show either of these features, which is also seen in dysplasias. So, coming to this congenital dyserythropoietic type 1, this is the second most common cause of this CDS, that is common in childhood, or they're detected just before birth, even in intrauterine life. And consanguinity is present and in subset of patients, and their parents are morphologically as well as presentation-wise are normal. There is an autosomal recessive pattern of inheritance. That means more than one siblings of the same family may be affected by these conditions. Transfusion dependency is usually seen in the first few months of life, whereas this may not be there. These patients may not be transfusion dependent towards later life. And as you all know that these patients, as the pathophysiology says, of ineffective erythropoiesis that leads to a chronic anemia, and there is ineffective hematopoiesis leads to jaundice, that is unconjugated hyperbilirubinemia. There is extramedullary hematopoiesis that leads to hepatosplenomegaly, and there is on long-standing cases because there is presence of this pigmented gallstones, and there is features of iron overload. Newborn babies may present with persistent pulmonary hypertension because of persistent low hemoglobin can lead to hypoxia, and hypoxia is a stimulus for this development of this pulmonary vascular changes, and that may be the cause of pulmonary hypertension in a newborn. So this Vikramasinghe group, they analyzed that 15 patients with congenital dyserythropoietic anemia 1, and in contrast to the other congenital dyserythropoietic anemias, this particular group of CDS, they are associated with dysmorphic features. That means the presence of, they demonstrated syndactyly in hands and feet, and you can see that there is abnormal phalanx. This particular left index finger phalanx is the terminal phalanx is hypoplastic. There is no terminal phalanx in this index finger. There is extra in the unusually long terminal phalanx of this middle finger. There is rudimentary ring finger, and you can see here in the right hand side there is what is known as there is presence of unusually flexed terminal phalanxes that can be seen also in some of the patients. So absence of distal phalanges, nail deformities, sometimes other phalanges in some fingers and toes, hypoplastic phalanges, additional metatarsal is not uncommon, additional phalanx, duplication of distal phalanx, great toes, hypoplastic nails, flexed fingertips, both hands. Short stature is a feature in the CDA1, brownish skin pigmentation, capulate spots, patches of depigmentation, flattened bodies of vertebra, hypoplastic right third rib, bilateral conduction and sensory neural deafness or impairment of speech. This was all present in their different cases in variable combinations. So coming back to this CBC and peripheral smear findings, you can know that that most cases of CDA type 1, they are present with lifelong anemia with a hemoglobin concentration of 8 to 11 gram per deciliter with a median concentration value of 9.5 gram per deciliter. As I said, mentioned with this, they are usually not transfusion dependent. They may be transfusion dependent in the initial phases of life just to manage the anemias, whereas in latter part type, they are not that much transfusion dependent. The classical CBC feature in a case of CDA type 1 is prominent macrocytosis. RBC are macrocytic with MCV that range from 100 to 120 femtoliter. There is striking anisopoikilocytosis with presence of there is increased red cell distribution width. There is presence of ellipticals, elliptocytes, teardrop cells, basophilic stippling, how else the bodies, all these things, as you can see here, these are the teardrop cells, and there is macrocytes, and there is presence of abnormal some threads of RBC which are scattered. These dense looking RBCs are possibly because of the transfusion which the patient have received, and they consider there is significant degree of anisopoikilocytosis, not much reticulocyte response in this case, as we expect that these patients have a suboptimal reticulocyte response. And on biochemical strength, we can see that this patient has a raised ferritin which ranges from 1000 to 1500 nanogram per ml. These patients, they are negative for acid-fied serum lysis test that I am going to discuss later. So this is the classical bone marrow finding in a case of CDA1. There is striking, this is a markedly hypercellular bone marrow with a striking erythroid hyperplasia, and there is this because of the striking erythroid hyperplasia, there may be an expansion of this the inner and outer table of the bone marrow that can lead to your skull bone abnormalities. There may be presence of megaloblastosis. But what is the most characteristic feature of this CDA1 is presence of this internuclear bridges, which is present in up to more than 10% of the erythroids, but at least 1% of the erythroid if you can show with this classical picture, then it can lead to a suspicion towards an case of a CDA type 1. This two arrows points to that two divided erythroids which have already finished that they completed their cell division. That have single erythroid has given rise to two daughter erythroids, but there is a presence of this erythroid internuclear bridges, that is like a thread-like connection between the two nuclei of the two daughter erythroids. This is known as prominent internuclear bridge, which is characteristic of CDA type 1. So as you can see, this is another diagram. We can see that prominent nuclear budding and multinuclearity is not uncommon, though it is not typically described in CDA type 1, but occasional erythroids can show multinuclearity. But nuclear budding, megaloblastosis, all features of dysbiosis, erythroid dysbiosis is expected in the case of CDA type 1. As you can see that this is a very thin internuclear bridge connecting two erythroids in the case of CDA1. So this is the parent of a patient child with a CDA type 1. As you can see here that these are the normal erythroids, and you can see that these normal erythroids have a smooth nuclear membrane, and which is the dark area is mostly the euchromatin, and you can see that this lighter area, electron lucent area, is the heterochromatin. And there is no abnormality to the nuclear membrane of this parent, which is, and you can see that there is presence of this is a single nuclear pore here, and which can leads to there is a single nuclear pore, and none of the erythroids in the parent had any abnormality, whereas the affected child of this parent shows characteristic pattern on electron microscopy. As you can see here, this is the erythroid and the nuclear envelope, which has widened nuclear pores, and that can lead to invagination of this cytoplasmic invagination into the nuclei, and that produces this type. And there is an increased amount of this heterochromatin, as well as this invagination of the cytoplasm into the nucleus, that gives rise to, this is the second diagram. As you can see that this is multiple vacuoles, and there is presence of this widened nuclear pores that leads to cytoplasmic invagination. And this typical appearance is what is described as the Swiss cheese pattern, and this is what is a Swiss cheese and what appears. So Swiss cheese nuclear abnormality, that means it's invagination of the nuclear membrane and membrane bound areas of cytoplasm that contains iron laden mitochondria within the nuclear territory, is a hallmark feature of this type 1 CDA under electron microscopy. And also to my right, you can see that this is a case of, this is a binucleated erythroid in a case of CDA type 1, which shows typical Swiss cheese like pattern. Now coming to the CDA type 2, this landmark paper by this Hempel and colleagues, which was published in Blood 2003, this was the initial description by this Hempel group, Hempel and their colleagues in 1967, when they described some of the cases, and then later on they traced about 43 families from the German and associated countries registries, and 43 families, 48 cases type 2 CDA, because this is the most common form of CDA, which is we all know that. And this group of researchers, they have followed up this 48 cases from these families over a period of 35 years. That means from 1967 till 2019, in 2001. And this is known as congenital dyserythropoietic anemia type 2. Epidemiology, clinical appearance, and prognosis based upon long-term observation. And this is the thing. And as was expected, most of the clinical hallmark of the features of these patients were, there was anemia, which was moderate degree of anemia, ranging from 9 to 11 gram per deciliter. There was presence of jaundice, which was unconjugated, mild unconjugated hyperbilirubinemia. Nearly 70, more than 70% of their patients had a palpable spleen and liver. Many had gallstones that developed, and a very significant subset of the patients, they underwent cholecystectomy before the age of 30 years. And there was evidence of iron overload, and iron overload that led to cirrhosis in a subset of patients. And also there was skin pigmentation, which was there because known as bronze diabetes. And there were only few patients, 5 out of 48% have died, two due to this iron overload related complications, whereas rest because of this unassociated complications, which is not related to this anemias. And all these cases, this criteria of the diagnostic criteria for CDA type 2 was in fact devised by this Hempel and Wendet. And what is the criteria that says that at least all the 3 A features and at least 1 B features must be present to call it as to stamp it as case as a CDA type 2. That means A1 is evidence of congenital anemia, jaundice, or hereditary evidence. A2 is evidence of ineffective erythropoiesis. A3 is typical morphologic appearance of bone marrow erythroblast with at least 10% binucleated red cell precursors. Type B, the B criteria includes B1 is positive acid lysis with at least 20% of the normal sera. B2 is typical abnormality of the band 3 and band 4.5 in sodium dodecyl sulfate polyacrylamide gel electrophoresis. Double membrane running internally from increasing age of the patients, this prevalence of splenomegaly as well as gallstones were increased. Whereas similarly, with increasing age, even without transfusion dependency, also there is increased level of ferritin. As you can, the solid line says that it is more than 300 nanogram per ml, whereas this dotted line below line says that ferritin more than 1000 nanogram per ml. So it is important at this point of time to note that this is because of the ineffective hematopoiesis, there is increased demand from the gastrointestinal tract, that means the duodenum, as well as lot iron metabolism becomes upregulated, and that leads to so iron overload does occur in patients with advanced age, and that is an important complications of this group of chronic anemic conditions like CDS. And these patients, the growth retardation occurred in 1 out of 41 cases, liver cirrhosis occurred in 9 cases, heart failure because of this iron overload occurs in 4 of the 45 cases where it was there, diabetes occurred in 9 of the 44 cases, hypothyroidism because gonadal this abnormality hypothalamo pituitary axis was also affected because of this deposition of this because secondary to iron overload. This occurs in respectively 2 and 3% of the cases. So this lab feature of CDA type 2 is much more characteristics and much more well delineated, described. The number of cases of CDA type 2 is much more than 1000 cases. Numerous registries have highlighted that this is the most common cause, this is the most common CDA type, that is CDA type 2. Mild to moderate anemia was 8 to 11 gram per deciliter, normocytic with moderate marked anisopoicocytosis. So in contrast to CTA type 1, which is microcytic, these patients are usually normocytic and there is moderate to marked anisopoicocytosis, teardrop cells, basophilic stippling, and new circulating erythroblast. As you can see that this is the bone marrow picture of the case with erythrodyproplasia, which is normoblastic. But it's not uncommon to find a megaloblast-like presentation in a bone marrow aspirate, and striking multinuclearity of the erythroid precursors, specifically intermediate to late erythroid precursors, intermediate and late normoblast with a typical, they demonstrate this typical multinuclearity of the nuclei, and this is occurs in up to at least 10 to 35% of this patients will show this binucleate and multinucleate forms in the specifically in the maturing or erythroid lineage. Whereas the early erythroid precursors like early proerythroblast or basophilic erythroblast, they rarely show this type of bio and multinuclearity in patients with CTA type 2. This acidified serum test, HAM test, is of historical importance, though it is still performed in some of the laboratories, and it was that the principle is that this particular group of CDA type 2 RBCs, they have a defective, these RBCs, they have a defective cell membrane, and when they are exposed to this acidified serum, and there is an activation of this alternate complement pathway, that leads to lysis of this RBCs of CDA type 2 RBCs. So patients' red cells are exposed at 37 degrees to action of normal or patient's own serum suitably, which is acidified to optimum pH of for lysis, that is 6.5 to 7. things only, whereas we all know that this test gives is positive in two conditions, that is paroxysmal nocturnal hemoglobinuria and CDA type 2. There is another reaction known as agglutination reaction, and additional serological finding in CDA type 2 is the increased expression of the fetal I antigen on this RBC membrane, therefore showing strong agglutination by both anti-I and anti-I sera during normal development. Transition from I antigen to capital I antigen takes place, whereas the determinants that define I and I antigens are carried by linear and branch polylactosamines. So this is a flow cytometric testing that bit of flow cytometric used in 5 malenomide tight binding assay. Red cells in CD8 type 2 displays this reduced EMA binding as shown by reduced mean fluorescent intensity in this flow cytometric panels, whereas other causes where this type of eosin 5 malenomide dibinding does occur is hereditary spherocytosis, pyropolycytosis, and Southeast Asian ovalocytosis. So it is important to remember at this point that CDA type 2 is a disorder of RBC membrane that causes defect in the RBC membrane, not the nucleus, whereas in CDA type 1 this is the nuclear abnormality, or that is very hallmark feature. That is that's why this ham test is not positive in a case of in CDA type 1. So how do you differentiate between PNS and CDA type 2? PNS is this positive in normal donor serum, whereas positive in 30 CDA this ham test is positive in 30 to 60% of normal donor sera. Positive in patient's own serum is PNH, whereas negative if you treat with patient's own serum, it is negative. Whereas PNS gives a positive sucrose lysis test, whereas CDA type 2 is negative sucrose lysis. And the mechanism of PNS is we all know that there is a deficiency or defect in the membrane glycoprotein linked proteins, anchor proteins that regulate the complement activity of CD55 and CD59. So this defect in this GPI linked anchor proteins leads to enhanced membrane attack complex mediated lysis of this RBCs. That is the mechanism in the PNS. Whereas affected red cells in CDA type 2 express unusual antigens which react with complement fixing IgM antibody present in many normal sera. That gives rise to this their lysis in this, their certain survival in a patient with CDA type 2. So it is the IgM mediated complement fixing IgM mediated antibody mediated the lysis because of the abnormal membrane of this. That is a picture of CDA type 2. So as you can see that the nuclei of this CDA type 2 erythroid precursors are perfectly all right. Their nuclear membrane, everything, the pore diameter, everything was all right. This heterochromatin, euchromatin, there is no evidence of Swiss like pattern as we see in the case of CDA type 1 or type 3. But what was the hallmark picture is there is a presence of this double membrane of this peripheral discontinuous double membrane in the late erythroid blast, and that gives rise to this, and this all results because of the abnormality of the endoplasmic reticulums that contains a specific enzyme that usually maintains this the cause of this double membrane pattern in a case of CDA type 2. So because of this the outcome of the CDA type 2, the membrane RBC membranes, their membrane, in some way the RBC of the CDA type 2 can be considered as a type of membrane defect like hereditary spherocytosis conditions. So this interesting article, which was published in British Journal of Hematology in 1977, and that means these authors they wanted to differentiate between this congenital dyserythropoietic anemia type 1 and type 2, and on the basis of aberrant pattern of this membrane protein migration, erythrocyte membrane protein migration in this SDS, sodium dodecyl polyacrylamide gel electrophoresis. And what it was found was that, so what they noticed is that in an electrophoretic pattern, you can see that this is the normal person's in the left hand side, extreme left hand side is the some cases of normal patient, As you can see that this is the right hand, you can see that band A, band zone, band B, band C. This is the normal, and this is in hemolytic anemias. This is in CDA type 1. This middle one, middle third and fourth are CDA type 1, and CDA type 2 at the right, 2 are CDA type 2. So what this authors observed in this pattern is that patients of CDA type 2, they have, there is something called as, there is a complete lack or maybe disappearance of the thinning out of this band 3. The band 3 in a CDA type 2 is characteristically is lost, and that gives rise to a quicker movement in the sodium in this gel electrophoresis. So this band 3 protein is significantly reduced in a case of CDA type 2, which was well maintained in cases with CDA type 1, as well as in other hemolytic anemias, as well in comparison there is a normal also. So this band 3, this table is what the table says, that is a summary of these things. Band 1.1 is lacking, that is band 3. This is 1.2 glycophorin, that is known as the glycophorin. There is a reduced electrophoretic mobility in one-dimensional electrophoresis. Deficiency of uranaminic acid is very likely. There is other protein like band 1.3 is unchanged. 1.4 is there is drastically increase in concentration, possibly associated with a change in the molecular structure. And whereas 1.5 B2 is increased concentration of B1.5, and whereas C2, there is a new component known as C2 is also there, that is also having this type of pattern. So the summary of this thing is that there is an increase. So all the authors have proposed that there is a defective glycosylation of membrane proteins in CDA type 2, and there is incomplete processing of N-linked oligosaccharides and in band 3 and 4.5. Hydrophobic abnormal band 3 protein cluster at cell surface, leading to increased binding to IgG, and hence there is an increased propensity for phagocytosis. So these are the main mechanism of reduced lifespan of the RBCs in the case of a certain lifespan of RBC in patients with CDA type 2, which is not seen in the case of type 1 or other CDAs. There is a paucity of literature that demonstrates there is the presence of this in a pattern of inheritance could be autosomal recessive or it could be sporadic, and it has some this is the rare forms of the initially described congenital dyserythropoietic anemias, and it is typically the hallmark picture is known as the gigantoblast. The erythroid precursors in the bone marrow are markedly enlarged. They are known as gigantoblasts. They have numerous up to 12 to 15 nuclei, and you can see here that there is no evidence of Swiss cheese-like pattern as it is seen in type 1, and whereas this is the giant multinuclear pictures. However, the Swiss cheese pattern can also be demonstrated in this type of patients with multinuclearity. So this is known as congenital dyserythropoietic anemia with giant multinuclear erythroblast, and which is relatively less common, and the exact prevalence of this particular entity is still not known. Now, while we are going from this classical presentation to this, and we must try to understand that the recent classification by this H.L. Ayalasan and Robert Russo in 2020, this beautiful article which is published in Blood, and that typically classifies that CD8 into CD8 type 1, CD8 type 2, CD8 type 3, as well as variants CD8 type 4, 5, 6, 7, and there are some other variants, that is mutation erythroid transcription factor like KLF and GATA1 associated CDS, which is or it may be part of Majeed syndrome, CDA with exocrine pancreatic insufficiency, or mevalonate kinase deficiency. So what they have found, they have analyzed from the multiple registries 218 subjects, and they have analyzed it through an NGS panel, and they have found that CDA type 2 is found to be the most common, as we have already seen, and you can see that the mutation of the protein known as the SEC23B is the commonest cause that is associated, and it is, you can see that 58.7% of cases of CDA type 2, and this is the most common abnormality, molecular abnormality is mutation of the protein known as SEC23B. Whereas as you can see that CDA, this is CDA1 is the mutation of CDA1, that is CDAN1 gene, that is 3.3% cases. CD that is known that codes a protein known as codanin, and then is known as CDA1B. This is codanin is implicated in CDA1A, and then C15ORF41 is implicated in CDA1B. Then GATA1 related cytopenias constitute about 1.58%. CDA4 is because of the mutation in the KLF1 gene, and there is syndromic CDA constituted on 0.4% of the cases. Acquired dyserythropoiesis 2.2% cases, whereas undiagnosed was significantly they could not diagnose what they could not categorize this entity in 17.3% of cases, and up to 14.8% cases this is known as some other associated 14.8%, nearly 15%. So what they have suggested is that the right hand panel you can see that this is the coding sequence length. Why SEC23B is found to be the most commonly mutated is because this coding sequence length is in a genome, this coding, this SEC23B constitutes around 77.9%. So that's why it is it tops the rank in this pathophysiology mechanism. That's why CDA type 2 is actually the most common because of this reason. Majority of our cases are actually falls into CDA type 2 because this protein has a very high coding sequence length, and you can see that CDA1 that is CDA1A 12.1% and GATA1 3.4%, KLF1. So this and in the y-axis is the rank pathogenicity of these cases of these individual genes. Next, our understanding about this why this morphological changes occurs in a bone marrow in the same group have highlighted. You can see that this is the nucleus, and this is the different stages of mitosis and prophase, metaphase, anaphase, telophase, and cytokinesis. That means the two daughter cells are produced with the two individual nuclei and their chromosomes, and you can see that this SEC23B, ACC23B is involved in this late metaphase stage. That means at the stage of mitotic spindle formation, they played its role at the stage of mitotic spindle, and whereas this C15ORF41, that is CDA1B, that is they play the role in this mitotic in the metaphase at the stage of metaphase. KLF1 is known as at the stage of post-metaphase level. So all these chromosome genes are implicated in the different stages of this cell cycle, the mitosis. And CDA type 1 is that as I said, that this is what is the nucleus. And you can see that these are the different localization of this inside the normal cell. This is the nucleus, and this is endoplasmic reticulum. This is what is your Golgi complex, and the SEC23B is located here, and it helps in your autophagy. And this CDA1 and C15ORF41, this is what is known as histone chaperone complex. They are important because this CDA1 is because of mutation in CDA1, C15ORF41, and GATA1. These proteins they are implicated in this. They play a critical role in DNA repair and or chromatin reassembly following DNA replication. I repeat, chromatin reassembly following a DNA replication. And this CDA1 with this encodes protein known as codanin 1, which acts in nucleosome assembly and disassembly through formation of the cytosolic ASF1 H3 histone 4 importin 4 complex. So this is the reason why mutation occurs at the CDA1 gene. So we expect that there is a presence of the typical internuclear chromatin thread or bridge, which is very classical of this of CDA type 1. Whereas SEC23B is an active role in assembly or deconstruction of the mitotic body during cytokinesis. This is things, and it is an autophagy. Also a role in autophagy. A pathognomonic biochemical feature of CDA2 is erythrocyte, is the presence of erythrocyte with an hypoglycosylated band 3, and that leads to an increased susceptibility for its phagocytosis. They are recognized by the phagocytes, and band 3 loss is the cause of reduced RBC survival. So I have not gone deeper into the rare variants and their molecular mechanisms. So, which is more complex and requires exhaustive understanding of our approach to them. So, how should you approach a case of congenital dyserythropoietic anemia? So, there should be family history and personal history has to be taken into consideration first. And once following that, this is published in the Blood Review in 2020 by this Iolason group, and this is Iolason's flowchart, and there should be CBC and biochemical parameter in the CBC, especially the hemoglobin, red cell distribution with mean corpuscular volume, and presence of reticulocyte count. Corrected reticulocyte count are mandatory because we do not expect any change in this TLC and platelets. And when if it is an hemolytic anemia, if we find to because of the reticulocyte count, if it is from the clinical presentation and from the biochemical data, LDH is an important feature and ferritin is important. If it is is it hemolytic anemia? If it is transfusion dependent, then we have to rule out there is thalassemias and acquired condition of hemolysis. Also, we have to do an NGS-based genetic testing, and where you can find the pathogenic variants of CDA related genes. And if you can do that, then that conclusively give a proper conclusive diagnosis of CDAs. If there is a CDA related genes, there is a variations, evaluation of morphological and biochemical features are mandatory suggested, and there is a different variant genes related to other anemias. There is a clinical re-evaluation is needed. But if it is a non-transfusion dependent anemia, then reticulocyte count, we have to look for that reticulocyte count. If it is elevated or normal, then we have to look for the possibility of RBC membrane defect. We have to go for this eosinamide things and osmotic fragility test to demonstrate this or rule out the osmotic the hereditary spherocytosis. And if it is normal or reduced, if the reticulocyte count is normal or reduced, then important that is it a case of CDA? Possibly there is a CDA is still a possibility. Syndromic CDA, then we have to go for NGS based genetic testing. And if the hemoglobin, fetal hemoglobin is more than 15%, platelet is less than 150, that means thrombocyte low normal platelet count, bone marrow examination is mandatory to rule out any CDA related events and factors, and then leads to different that should proceed for different genetic testing. And whereas if MCB is the three important parameters is reticulocyte count, hemoglobin AF estimation, and MCB. If it is normal or elevated, that means we have to band 3 hypoglycosination, skeletal malformations to be looked for to rule out for the possibility of CDA type 1. If it is normal or decreased, then it can be classical CDA 1, 2, or even 3 also. So an interesting article that was published in Clinical Lab Hematology in 2018, 2001, that CDA type 2, one of the very important mimickers of CDA type 2 is hereditary spherocytosis. Many cases of CDA type 2, as has been described by the Hempel et al. In the group in the study of 48 cases, were diagnosed more than 30 years, after 30 years of age, even 68, 70 years of age. The reason was possibly this has a lot of misdiagnosis, as many cases were misdiagnosed as a case of hereditary spherocytosis. And CDA type 2 is frequently misdiagnosed as hereditary spherocytosis due to the presence of mild chronic hemolytic anemia with splenomegaly, increased osmotic fragility, and presence of microspherocytes in the peripheral blood. So all these features makes this diagnosis more confusing as with hereditary spherocytosis. So these authors, they have done from the CDA 18% from 8 families of with hereditary spherocytosis, 10% of with CDA type 2, and 50 normal controls they evaluated. And what was the characteristic feature of CDA type 2 was that there was a striking increase in red cell distribution width. But that means CDA type 2 cells are more anisopoikilocytic, whereas the hereditary spherocytotic cells, they have showed more amount of anisochromasia. There is minimal anisopoikilocytosis, that is known as HDW, that is hemoglobin distribution width, because of the presence of spherocytes, resulting in a increased RDW to HDW ratio, which was significantly greater in CDA type 2 than hereditary spherocytosis, with a significant value of less than 0.0002. That means hereditary spherocytosis patients, the CDA type 2 patients are more likely to have a significantly increased red cell distribution width, that means anisopoikilocytosis, is very common, whereas in hereditary spherocytosis is the anisochromasia. And a cutoff value of this RDW to HDW of 5.34 result in an 89% sensitivity and 70% specificity in distinguishing CD8-2 from hereditary spherocytosis. So this could be an interesting finding that we can also look into our cases, but when we have suspicion towards both, and both can show because of the presence of microspherocytes, and CD8 type 2 has a membrane abnormality, they are more fragile. So hereditary spherocytosis is the greatest mimicker of CD8 type 2. Osmotic fragility test might be misleading in this type of cases. So in this type of cases, we can go for this type of analysis by flow cytometry. So this is the summary of my talk, that we discussed about the three more common types. There is type 1, type 2, and type 3. Type 1 and type 2 is type 2 known as HEMPAS, hereditary erythrocytic multinuclearity with positive acidified serum test, HAMS test, that is autosomal recessive. 3A is autosomal dominant, 3B is autosomal recessive, and the chromosome localization is chromosome long arm of chromosome 15 in type 1, long arm of chromosome 20 is in type 2, and the 3B variant is still not known, but it is still in the chromosome 15 long arm is 3A. Macrocytosis is usually a feature of type 1, and anisopoikilocytosis with normal MCB is a feature of type 2, whereas macrocytosis can be seen because of the gigantic giant nuclearity in the bone marrow. So macrocytosis is expected. This HAM test is negative in both type 1 and type 3, positive in type 2. The peculiar band 3 pattern of RBC membrane in SDS phase electrolysis is a hallmark feature in type 2, and it migrates faster, whereas in type 3 band 3 migrates very slightly faster than the normal, not like that of CD8 type 2. The nuclear in the electron microscope picture is very characteristic in type 1 and type 2. The switches appearance of the heterochromatin, and this chromatin bridges the peripheral double membranes due to the endoplasmic reticulum mediated changes is a hallmark feature of type 2, and giant multinuclearity in type 3. And this is the summary that is those who are, you can see that there is not much difference in the male to female residence. Incidence, as I said, it is most common is type 2, and mostly it is found in the Germans and the Italians. The anemia is mild to moderate in most of the cases. Type 4 can be severely hemolytic picture. The macrocytosis, this presence of this binucleated normoblastic features in up to 40% of cases is a feature in type 2. Gigantoblast, up to 40% of this gigantoblast is feature of type 3. This internuclear bridging is very much characteristic feature of type 1. Electron microscopy, I have already described. This SDS space electropoiesis patterns are also described, and the presence of this acidified serum hemolysis test, HAM test, is positive only in type 2. So with this, I come to a conclusion of my end of my talk, and thank you so much for the patient hearing.
Thank you, sir. As usual, excellent talk. Very crisp and very, very informative. Very nicely done. And just please hold the line. Let me check if there are any queries and questions on the YouTube. If there are any questions on the Google Meet, anybody can ask straight away. What is your personal experience with CDA, sir?
I have never seen a case of CDA after my MD. So that means 2005 to 2008 I did my MD, and I was lucky to at least this binucleated forms and internuclear bridges morphological features in a pediatric patient, because the Department of Pediatric and was too good in Cuttack. They had we used to have an interdepartmental hematology and pediatrics meet where maybe twice or thrice some at least the differential diagnosis of CDA type 2 was brought because of the presence of this multinuclearity and dysbiotic forms, transfusion dependent anemias, and mimic like hemolytic anemias. And after that, I have never seen a case of CDA or even a DD of CDA since 2010. I went to Pondicherry, even in not Nizam's never had this pediatric department, so I never had that. Uh, uh, this exposure. But after joining AIIMS Bhubaneswar, yes, very strong pediatric department. We do get some congenital anemias, but morphology has been classically described in bone marrow. Till now, we have not seen a typical case of internuclear bridging or a binucleation. Binucleation is there, but in a clinical context, I don't remember if we have seen a case like typical where we can have a DD of a CDA at least, CDA type 2 at least, so that we can suggest for a molecular testing. That personally we have not seen till now. But hopefully we can, because this is AIIMS Tertiary Care Center and with a good pediatrics neonatology department, pediatric hemato-oncology, very good department here. So we are likely to encounter these cases at least morphology wise, so that we can suggest some of the cases for molecular testing studies.
How frequently do you see hereditary spherocytosis?
Hereditary spherocytosis we do see, but not that frequently here. They come very sporadically. But do they, at least the clinicians, they ask for a osmotic fragility test and MCHC and presence of spherocytes with typical presentation. We do see maybe 1 or 2, maybe 3 to 4 cases per year, or in that we do get cases of hereditary spherocytosis.
Okay, good. Right. Wonderful presentation, Dr. Somanath Padhi, and as usual, very, very knowledgeable. You're very
Thank you, sir.
knowledgeable. And I think we have to ask you to come back again with
Yes.
HLH. It's a subject of demand, and everybody wants you to talk on that because you're an expert in
I'm
that.
not an expert actually, sir, but I am very much fascinated towards that because the reason is that it has a lot of good memories that has evolved me in that. So I have done a lot of studies on that, and a lot of discussions with. Sir, as I said in the last class, that I have always preferred to discuss rampantly with my clinical colleagues as well as my fellow colleagues, and that's how I have evolved. So HLH, because I'm lucky here that we get cases HLH here, as well as good senior hepatopathologist. My HOD here is a hepatopathologist, and we do get to see cases of liver biopsies. And in Dr. Susma Patro, she's the HOD of pathology out here, and we are lucky that we get to see cases of postmortem liver biopsies and patients who are dying of macrophage activation and things. So and we have written a book chapter. One of my book chapters is on hepatic histomorphology in cases with HLH, and I will be very much happy to share my thoughts and with my experiences in
Sure,
future.
it will be a proud privilege for us to have you on the platform speaking on HLH. So
Yes,
we will definitely invite you maybe sometime next month if you are free. I will definitely get in touch with you, and
sure,
we'll
sir.
fix up a mutually agreeable time.
Yes, sir.
And we would like to listen to HLH and learn from you from HLH.
Thank you, sir.
Uh, Thank you, Dr. Somanath Padhi. It was a pleasure having you here. It was a pleasure listening and learning from you. So much to learn. Excellent teacher. Very nicely. You are a very good teacher. Excellent teacher. Thank you so much, sir.
Thank
Take
you, sir.
care. Bye bye. Bye bye.
Thank
Good
you, sir.
night.
Thank
God
you so
bless
much.
you.